Welcome back, everyone, from our short break. We are heading into the second half of our presentation today, and I just want to remind you, if you would like to ask a question, you should be able to see a little Q&A box in the upper right-hand corner of your screen at this point, and feel free to chat in your questions throughout the presentation in part two, and we will be moderating a Q&A session as soon as our presentation concludes. And we'll get started right away. So Colleen, I'm welcoming you back, and you're going to take over from here.
All right. Thanks, Nicole. So yes, welcome back. I'm really excited to welcome our next speaker, who is Dr. Kathy Lohman-Hirth. And Kathy assumed the position of director of the ALS Center at the University of California in San Francisco in 2004. She has been an ALS specialized clinic in the clinic, and it has been one of the ALS Association certified treatment centers of excellence since 2005. And that's actually one of the centers that Neil and I were just talking about in our previous segment. So now you've got someone with that real live experience that can talk about it. She follows over 375 patients with ALS with 100 new referrals each year, and oversees and coordinated work with a full multidisciplinary team that we were just discussing. Those professionals include people that have specialties in speech pathology, dietary expertise, social work, physical therapy, occupational therapy, respiratory therapy, nursing, and other healthcare providers. So you can see how rich that kind of team really is in helping people living with ALS. Dr. Lohman-Hirth participates in ALS-specific research and is particularly interested in research involving electrophysiological and genetic predictors in ALS. So, Dr. Lohman-Hirth, welcome to the stage.
Thank you very much. I really appreciate you inviting me to speak today, and I look forward to talking through how we optimize treatment and care for ALS. Next slide. I'm going to start with talking about the steps in the care coordination for ALS patients. So first, making the diagnosis and breaking the news. There are specific guidelines for neurologists on exactly how to do this for ALS. It's a complicated diagnosis to make. It is made as a diagnosis of exclusion. We have to look at all of these other things that it might be. And when a patient has a particular neurological exam, particular EMG findings, and all of the other testing is negative, then we're able to conclude that ALS is the diagnosis. Once we make the diagnosis, we want to immediately start treatments that help slow the disease process. And fortunately, we have two treatments that are FDA approved to slow the disease process, riluzole and Radicava. Unfortunately, these treatments do not reverse weakness, but there are many exciting drugs in development that will more significantly slow progression or someday even be able to reverse weakness. So we're very hopeful about the progress being made by our research colleagues. What I'm going to be focusing on today in the talk is what can we do now? What can we do now to help symptoms that are uncomfortable for ALS? And how do we help patients and families through this process utilizing the partnership we have with the ALS Association, as well as our multidisciplinary team. So we're going to be talking today about how to manage symptoms such as shortness of breath, difficulty swallowing, losing weight, how to best optimize functioning when strength is lost. And then we'll talk about things like end-of-life planning, how to support the family, and we'll talk about what we expect in the future as COVID ends and as we think about how to utilize telemedicine going forward. Next slide. So I mentioned that there are a lot of things we can do to help with symptom management, and that is due to the changing in the management of ALS patients for both a better quality as well as quantity of life, advances that have just happened within the last few years. So the ALS Association has certified many more centers to help with multidisciplinary care of patients with ALS. We have better diagnostic processes for genetic testing. There's even prenatal testing options for patients with familial ALS. We have more clinical research opportunities for patients than we ever have had before. Over 130 companies are working actively on ALS treatments right now. We have a better recognition of symptomatic issues and advances in technology that help us better manage things like nutritional issues, breathing problems, depression, mobility, and lastly, our multidisciplinary care, which we know based on research that is the one tool we have that slows down the disease process and improves survival as well as quality of life better than any other drug or tool we have. So that multidisciplinary care is so important. Next slide. This slide talks about the frequency of symptoms that patients with ALS have. And I want to highlight that at the top of the list are symptoms that are painful: muscle cramps, twitching of the muscles, stiffness. And then it goes on to talk about things like depression, excess saliva, anxiety. These are all symptoms that we can manage with medications. And so it's important to be connected to a multidisciplinary care center to help with treatment for these symptoms. Next slide. I've been talking about multidisciplinary care. Well, what does that mean? So a center that is certified by the ALS Association, and you can easily look on the ALS Association website and find what are the certified centers in your state or in a nearby state. And these are centers that are required to have a full multidisciplinary team that sees all of their patients with ALS on a regular basis, ideally every 3 months. And that team includes a neurologist, a nurse, a dietitian, a speech pathologist or speech therapist, a physical therapist. Physical therapists tend to focus more on leg function, and occupational therapists focus more on arm function. Respiratory therapists who help with breathing. Social workers who often are certified to handle mental health issues and counseling as well. And then the ALS Center Liaison, who is a person who comes to the clinic regularly and is able to meet with patients and families and connect them with local services and support groups in their area. I'm very fortunate in California, where we have a very strong local ALS chapter that has funding to provide ALS care managers in various regions throughout California. So we are able, through their support, to have 4 satellite clinics in Fresno, Modesto, Monterey, and Santa Rosa, which are neighboring towns to San Francisco, but far enough away that it's hard for patients to travel regularly into clinic. So our partnership with them is critical, both for referring patients to us as well as helping us manage patients in between the clinic visits. Next slide. So I'd like to go through now some hard questions that patients often ask when they come to clinic, and how our multidisciplinary clinic addresses these issues. So what I'm going to cover in the next few minutes are answers to these questions. Should I get genetic testing? I'm losing weight. Should I get a feeding tube? I'm short of breath. What are my options? I'm falling, and my family's worried I might not be safe to drive. Should I exercise? People don't understand me when I speak, and writing is hard for me. How do I know if I'm depressed? So the first question, should I get genetic testing? Here's some of the questions we ask in order to help answer this question for our patients. We ask, would it change management of the condition if we knew the genetic cause? For patients who have a familial form of ALS, meaning that they have a family member, an immediate family member who had either ALS or dementia, there are clinical trials currently ongoing for treating 2 of the genes that we know cause the genetic form of ALS, SOD1 and C9orf72. And so for patients who have a family history of ALS or dementia, it can be very valuable to get testing, because the answer is yes, it would change management, because we would refer patients to a clinical trial so they could have access to these exciting potential new therapies to treat these genetic causes of ALS. We also ask the patients, has anyone in the family already been tested? That makes it easy. If a known gene is in the family, then we can just look for that specific gene. We want to know if the testing might be free. So sometimes testing can be free if a clinical trial is looking for patients. They'll often offer testing for free. And the NEALS organization, the Northeastern ALS Group, which is encompasses neurologists from around the country. They will offer free testing for any patient who has a family member with either ALS or dementia in their immediate family, so one of their parents having that condition. And then we think about, well, what if the patient wants to have children? Would they want that information available? Is prenatal testing available? And then it's very important to know, does the patient's insurance or other nonprofit organization cover the testing for the suspected diagnosis? More and more companies now are offering free genetic testing for a variety of neurological diseases, including ALS. And then lastly, has the patient undergone genetic counseling first? It's very important to understand the implications of a positive test or a negative test on not only the patient, but on their immediate and extended family. So that's very important as well. Next slide. I'm losing weight. Should I get a feeding tube? So there can be lots of causes of weight loss with ALS. It can be due to difficulty swallowing, or someone may have perfectly normal swallowing function, but their arms are weak and it's very hard for them to have access to food. Shortness of breath burns a lot of calories, and so patients can sometimes lose weight if they can't keep up with that increased energy expenditure, either from shortness of breath or from weakness with walking. A patient with significant leg weakness walking across the room may burn the same number of calories as someone with normal leg function who is running a mile. So it's very important to recognize the increased calorie needs in ALS, as well as the impacts of both swallowing difficulty and arm weakness. And we have a variety of aids that we can use to help support these problems. So we can help with, there's various tools to help with eating more easily if you have arm weakness, and also breathing support if someone is having shortness of breath, as well as modifying the diet and changing food consistency. And then ultimately, when these measures don't work and the patient's still losing weight, we think about having a feeding tube. So our dietitian on our team and our speech pathologists are very important team members. They go in together to see patients and help walk them through how to cope with this problem. Next slide. I'm short of breath. What are my options? So shortness of breath is most likely caused from diaphragm weakness. The diaphragm contributes 75% of our ability to breathe properly. There can also be chest muscle weakness contributing to that as well, and increased energy expenditure. And so, as already mentioned, there are these non-invasive breathing devices that patients can use that help support their breathing and allow them to be much more comfortable and have a better quality and quantity of life. And then ultimately, invasive ventilation is an option that approximately 1% of ALS patients choose, where patients can have a tracheostomy and live potentially a normal lifespan on an invasive ventilator. Next slide. I'm falling and my family's worried I'm not safe to drive. So many employers will have teams of people that can work to help optimize the home and work environment so patients can work as long as they desire to work with this diagnosis. Anticipating equipment needs is always a good idea so that patients have equipment before they think that they need it. And that's where our occupational therapists and physical therapists are very critical to our team to assess and anticipate needs that patients may need, whether it be a walker or a wheelchair or a Hoyer lift to help with transfers. And then any DMV will do a driving assessment for safety and can certify patients are safe to drive for 6 months, and then they would need to be reassessed. So anyone who wants to drive can have a driving assessment to prove that they are safe to drive. And then lastly, exercise is always tricky, knowing how to advise patients how to exercise the right amount, not too much, so that the muscles that are weak are over-exercised, but not too little, so that patients have muscle atrophy because of disuse. And so that's where the physical therapist and occupational therapist can work to guide that form of exercise. And they often will work with local physical therapists and occupational therapists in the home or in the local outpatient physical therapy and occupational therapy centers to help advise specific ALS guided treatment. Next slide. People don't understand me when I speak, and writing is really hard for me. So this is where our speech therapist is very effective at helping to understand what is the best communication strategy for an individual patient. Sometimes it's simple tools like an alphabet board or a voice amplification system or text-to-speech software. And sometimes more complicated systems are needed, like eye gaze systems, where patients can type out words with movements of their eyes. And so the speech therapist works with the patient over the evolution of the disease to determine the optimal system for them. Next slide. Am I depressed? This is a stressful disease to adjust to, both for the patient and for the family. And depression and anxiety are very common, and there are very good medications to treat these conditions. Mirtazapine is one of my favorite because it helps with sleep, mood, and appetite. So it does 3 different things. Support groups are also very, very important. And the ALS Association has a wonderful range of support groups that are easier for patients to attend than ever now that most of them are virtual. And then sometimes patients with ALS can have difficulty with easy laughing and crying. They feel fine, they're not depressed, but they find themselves laughing at a joke that really isn't funny, or crying uncontrollably with a sad commercial. And this symptom is very easily managed with a drug that was approved in 2012 for ALS called Nuedexta, combination of dextromethorphan and quinidine. And in some patients, it can even help improve speaking and swallowing. So it's been a very effective medication that we have added to our regimen since 2012. And then lastly, I wanted to say a word about frontotemporal dementia. Cognitive and behavioral dysfunction can occur in about 50% of patients. It's often very subtle, a little bit of word finding difficulty, trouble with managing multiple tasks at once. But sometimes, rarely, patients can have more severe symptoms and can meet criteria for frontotemporal dementia. And one of those symptoms of frontotemporal dementia can include apathy and a lack of interest in activities disproportionate to the disease progression. So that's important to be aware of as well. And that's treated in a specialized center with primarily behavioral techniques. Next slide. I want to say a word about palliative care, and then we're going to turn to talking about telemedicine. So it's important to think about palliative care in the beginning, and it's important to talk about end-of-life issues in the beginning. Many times patients, when they receive a diagnosis, are very frightened because they understand and have heard that this is a fatal disease, but they don't necessarily know what that means for them. And it's so variable. I've had patients who have died 2 months after their first symptoms, and I have other patients who are still walking 10 years after their first symptom. So there's a huge range of rates of progression, and every patient needs to be treated in a very personalized way. We partner with the palliative care team at our institution and enroll patients to see them almost as soon as they are diagnosed, to help with adjusting to that diagnosis, partner with pain management, help with the decision about when to involve hospice. And either our palliative care team and our team follow patients right until the end of their life, even after they're in hospice. Next slide. I want to turn in the last few minutes to talk about the effects of COVID-19 and telemedicine, and to talk about what we foresee for the future. There have been a lot of benefits for ALS that have come out of COVID-19. First of all, insurance companies universally allowed payment for patients to be seen by telemedicine, even patients in nursing homes. And so that meant patients we hadn't seen in years, we were able to see via telemedicine for patients who were in a nursing home or patients in far-flung areas of California where it was hard for them to travel. Also, ordering specialized equipment for patients with ALS, such as a speech generating device, a power wheelchair, and other equipment such as non-invasive ventilation to help support breathing. We used to have to bring patients physically into clinic, do a very detailed neurological exam, and then justify to insurance why this equipment was needed. Now, all we have to say is, this patient's having difficulty speaking, this patient's feeling short of breath, this patient's having trouble walking, and that alone justifies insurance now to cover that equipment. So it's been phenomenal how much earlier our patients have been able to get these important types of equipment. And lastly, because multidisciplinary care, we've been able to provide that even better with telemedicine, because we can have as many virtual breakout rooms on Zoom as we want to room our patients and have our specialists rotate in to see the patients virtually. We've been able to see many more patients. We've been able to expand our care outside of California. We have a telemedicine clinic with all of the different islands in Hawaii now. And we've been able to see patients more frequently because it's so much easier for them to be able to come to clinic. They just have to wake up and turn on their phone or their computer and log into Zoom, and then they're ready to start. So we've been able to see patients earlier, to diagnose patients earlier. We've been able to follow patients more closely, and we've been able to see patients in areas of California and outside of California that we've not been able to care for prior to COVID. Next slide. So in summary, we can treat many of the symptoms of ALS much better than we could previously. Equipment advances are allowing patients to be more independent than ever. Communication options continue to expand, and multidisciplinary care is the most important treatment we have to prolong both quality and quantity of life. Next slide. So what are our collective goals? In the last couple of minutes, I wanted to talk about what would we like for the future. We would like to expand access for patients with ALS so that all patients with ALS can have access to a certified multidisciplinary clinic to obtain the care that they need as soon as they are diagnosed with ALS. Secondly, we want to expand access to all patients with ALS to clinical research trials. The ALS Association does a great job on their website of publicizing trials that are available throughout the U.S. for patients with ALS, and many of the companies who are testing drugs in ALS recognize the challenges of traveling for clinical trials, which often involves an in-person visit once a month. And so some of them are going to 100% virtual visits for their clinical trials, or they're willing to pay for gas and hotel for patients to travel. So more than ever, ALS patients have wonderful access to clinical trials as well as to multidisciplinary care. And then we want to advocate so that insurance continues to provide these very essential equipment without requiring those detailed evaluations and that in-person visit. We want to make sure that patients have what they need in terms of the ability to connect for telemedicine, having an appropriate cell phone or a way to do these video visits, and then education about what to look for. The ALS Association is working hard to try to educate neurologists and primary care providers in the community about what are the symptoms of ALS and encourage them to refer patients with any sign of progressive weakness of unclear etiology to a ALS certified center so that these patients can get diagnosed quickly and can get the appropriate treatment that they need. And then lastly, we want to think about how can we best evaluate the things that we do to try to continue to improve the care for our patients and for our families to ALS. Next slide. So I'd like to just acknowledge all of the people that I work with in the ALS Center. This is us doing the Ice Bucket Challenge in front of UCSF Hospital, and I'm very grateful for their partnership and support, as well as for the support of the ALS Association for funding our clinic all of these years. Thank you.
Thank you, Dr. Lohman-Herth. That was a fantastic presentation, and we really appreciate you participating today. And I'm really looking forward to you joining us for our Q&A session in just a moment here, because I have a lot of questions for you, as expected. So I am going to bring back several of our panelists from today, so we can have a Q&A session. As a reminder, if you want to ask a question, you can look for that upper right-hand Q&A button and go ahead and chat in that question. But we do have several waiting guests already, so we're going to jump right in. So I'm welcoming back Tommy May from our Board of Trustees, Colony Balas, of course, our President and CEO, Dr. Neil Thacker, our Chief Mission Officer, and of course, Dr. Lohman-Herth, who you just heard a wonderful presentation from on optimizing current treatments and care. So I am going to start with you, Kathy, because many of the questions are specific to medications and symptoms management and things like that. So here's a really interesting question, though, that I'd love to hear from you about. So, and it's specific to riluzole. So this individual was diagnosed more than 5 years ago, and they're wondering if riluzole is only effective for 6 to 19 months. Does that mean I should stop that treatment right now?
Yeah, thank you. That's a great question. New research shows that riluzole is effective at every stage of the disease, even at the very end stage of the disease. So most of our patients continue on riluzole until the last day of their life. It's always hard when you have a treatment that's slowing down the rate that you're getting worse because you can't see yourself whether it's having an impact on you, but I think you can trust the data where patients have been studied throughout the course of ALS and compared to people who are not taking the drug, and it has shown a benefit all the way up until the very end of life.
Yeah, and to clarify, Nicole, that slide I showed that mentioned the paper that Jinsey wrote about riluzole, it was about the additional months of life that riluzole grants. It's not about when the drug is most effective.
Thank you. I appreciate that very comprehensive answer, because that was definitely something that I was curious about as well once I saw the question. Another question I'm getting, and this has been a theme actually throughout the last 2 days, is specific to genetic testing. And you have, of course, mentioned the importance of genetic testing, and as well as potential of prenatal testing. But what do you do if there's a positive result? How does that help to know that information? Dr.
Yeah, that's a great question. So right now, if you have a positive result and it shows that you have either SOD1 or C9orf72, you can enroll in clinical trials with designer therapies that are specifically targeting that gene. And the preliminary data from these trials looks very, very strong. And so that's the main reason to get the testing and to see if you have a gene, if you have familial ALS. And I really want to emphasize that, because there's a very low likelihood of having this gene test come up positive if you do not have a family history of ALS.
Thank you. Neil, I have a couple of questions specific, as Dr. Loman-Huth was just referring to clinical trials. I am getting a couple of questions about clinical trials, and the main theme of those questions is, why is it so hard to get into a clinical trial?
Yeah, it's a great question, and the reason it's so hard is because we know that the drugs, in order for a drug company to see an effect of a drug in a short period of time, it means they need to enroll patients in that trial that are more rapidly progressive, so that they can see differences during the time period of the trial. So we have patients with ALS who sometimes hardly change over a year if they're very slowly progressive. And if they were in a clinical trial, it'd be very hard to know if the drug is having an effect. And so for clinical trials, what tends to be important is to try to enroll people who've had symptoms for a very short period of time, often just 18 months or 2 years, to try to capture that more rapidly progressive group of patients, and to try to capture patients who are earlier in their disease process, so they are not receiving some of these disease-modifying therapies like the non-invasive ventilation I mentioned and the feeding tube, treatments that can prolong life on their own. So you want to have a fairly homogeneous group of patients in the trials that are progressing fairly quickly, so that a company can see differences in their drug and then be able to, in a fairly short period of time, so that they can apply to the FDA and then hopefully get approval for any drug that looks promising. But I just want to say one more thing about how all of this is changing, and that is with the Healy platform trial, where many drugs can be tested at once against one placebo control, and that means that only about 20% of patients need to be on a placebo. The rest of the patients can be on active treatment, and the design of the trial allows drugs to more rapidly cycle through, so that we don't waste a lot of time testing a drug that looks like it's not effective.
Thank you. That's incredibly helpful. And, the other theme that I'm getting over the last couple of days, and Neil, I'm going to direct this question to you. I'm getting a lot of questions, for instance, about the CARES Act 2.0, and specifically about caregivers. And so the questions I'm getting is, are we lobbying at all for more allocation for caregiver support, as well as, are we looking to draft legislation that supports givers, particularly in the mental health space, as well as, of course, for respite care and other challenges that they have?
Yeah, that's a great question. And it's not straightforward, because this long-term care challenge is a challenge that isn't unique to the ALS space, but it's especially intensive for families impacted with ALS. And we don't have a lot of evidence to support how intensive it is. And so we've been doing a lot of coalition work with groups like the AARP and Disabled Veterans of America, and other groups, Paralyzed Veterans of America, I'm sorry, to get more caregiving benefits wherever we can. So there's some caregiving benefit relief that's in one of the recent Biden legislation stimulus bills. We're working things through the VA. We're developing our evidence base for caregiving so we can work it into other kinds of legislative products. And we're talking about it in the context of Medicare and this Cures 2.0, this big overhaul of the FDA and Medicare. But it is a very complex situation, and I don't think we have a winning strategy for it in ALS yet. We're still putting the pieces together, and I think that's part of this making ALS livable, is giving us that focus of where to work, because it's such a huge problem. And that actually gets to one of our parts of our ask for this year, which is this National Academies study, because we do need the entire federal government to really think about not only what ALS is and how to treat it and cure it, but how to manage it and what the impacts are for all of our families that are impacted by it. And that whole holistic response does need coordination across the entire government. And that's where we're hoping the academies can provide some leadership.
Thanks, Neil. And I think, speaking of some of our legislative asks, I wanted to focus on Tommy May for just a moment. Tommy, I wondered, I got a question for you specifically about sort of your very active nature in the advocacy space. And, for some of the people with more limited experience in advocacy, what do you believe are the key areas or activities that people can become involved in to support this legislation?
Yeah, thank you for that. First of all, is really we stay engaged, that we get to know our congressmen and our congressional delegation, and we stay in touch with them. If there's anything that all of us can do, it is to work with our congressional delegations that truly can make a difference in the lives of all of us through the dollars that they help allocate to the various programs. And another thing that I think is very important is not only know them and stay engaged, but obviously the advocacy that we do, that we take time to go to Washington, to go wherever we can to make a difference. And the best way to make a difference is to be right in front of somebody that understands ALS, and that you can simply talk to them one-on-one and let them know that you need their help. So the best thing is be willing to ask for their help.
Thanks, Tommy. And you hit on something that I think we've heard repeated a lot this week, is just get in front of them and tell them your story. And that's the most powerful tool that we have in this process. So I want to switch gears because I'm getting a lot of questions for Dr. Lomenhirth in particular around telemedicine. And so one of the first questions I wanted to ask you is, are you seeing a difference in the number of people, more or less, people returning to clinic after COVID, as well as how telemedicine has helped you throughout COVID in the process?
Yeah, thank you. So the first thing we did when we were shut down is we called personally every single one of our patients to let them know that we were still seeing patients and we were seeing them via telemedicine, and explained how that worked, explained that all they need is a cell phone or know someone with a cell phone so that they can connect with Zoom. And we asked patients if they would like to come in for an appointment virtually. So we did that in March, right the week that we were shut down. And what we found was there was a really overwhelming response of patients that wanted to be seen. We answered a lot of questions around COVID, how to stay safe, where to get testing, and once the vaccine came on board, answered a lot of questions around that. And what we found is once patients experienced telemedicine, I mean, we had people who were 80 who had never even used the internet who were able to use a cell phone or have their grandchildren help them figure out how to download Zoom and connect. And we found that people liked it so much, they said, please tell me I don't have to come back into clinic. Tell me I can continue to see you virtually. And so we find that very few people, even now that we are open to see patients in person, very few people are choosing to come and be seen in person because of what I mentioned. All of those relaxation in insurance requirements means that patients don't have to come in to get all of the things that they need, and we're able to see patients much more frequently than we did before. And so we've actually had to create some extra clinic spots because of the robust response. And then referring providers, knowing that we can see patients via telemedicine, even new patients, our referrals have also gone way up. And as I mentioned, being able to see people in nursing homes allowed us to see patients that we had not seen in years. So I would say that patients are definitely being seen earlier, they're being seen more frequently, and we're seeing many more patients.
Speaking of referrals, there's a question in here in particular that is striking because of the challenges of not seeing your neurologist all the time when you have ALS, right? So one individual is describing one of their biggest challenges were hospital visits. And maybe we could talk a little bit, maybe Kathy and also Neil and Colleen, about what we're doing to educate other physicians in this area, in this space, to ensure that hospital visits are maybe a little bit easier for someone with ALS.
Yeah, no, thank you. It's a great question. And one of the things that is required by being an ALS certified center is that patients need to have a way 24/7 to be able to reach an ALS physician. And so what that means is that if patients call our ALS Center Line, they receive a pager number that they can call, they can task advice if they should go to the ER, and once they go to the ER, they can provide that pager number to the ER doctor and encourage them to call, or they could call the whoever's on call and say, hey, I'm in such and such an ER, do you mind talking to this doctor? And then they can hand their cell phone over to the doctor. So we try to communicate with the providers at outlying hospitals when our patients are in the hospital so that they can get that care that they need. And we also try to educate patients about what they should do if they are in an ER and someone says, oh, we want to put oxygen on you. Well, we know that doesn't work for our ALS patients if they don't have their BiPAP on, for example. So we educate our patients, we give lectures to community neurologists, and we also try to make sure that patients have that way to access us 24/7 with questions. So I'll stop and let some of the other people you mentioned chime in.
Yeah, thank you, Kathy. It's a complex parts of information that have to move across different providers, and there's really two parts to that. I think that the association is playing a role in. So Kathy mentioned information that clinicians, especially emergency room physicians, need when someone with ALS shows up. When the pandemic was starting and there was a lot of pressure on emergency rooms and hospitals, we were especially worried, even more than usual, about people with ALS going to the hospital. And so I think we updated, although they were actually really solid anyway, patient information cards that people with ALS can carry with them, that they can share with their provider, they can share with their ambulance crew, and they are on our website, and we can probably point people to those again, because they really are important information to help people manage that chaotic transition into care, especially when they can't get a hold of their ALS physician or their specialist. The other part of this is a little more complex, and that is we have these amazing world-class treatment centers like Kathy's clinic, but they're not everywhere in the country, and people with ALS have challenges accessing them. And I'm concerned that some of our folks, maybe even some of the folks here, have given up on trying to get to clinic. But what I hope they're hearing from Kathy's presentation is that things have changed a little bit under COVID. And so treatment is more accessible than it might have been when you last checked. And so I would really encourage people to talk to their chapter and let them know where they are and see what can be done. Because even if they checked even 8 months ago, 9 months ago, things might be different today, and we might be able to get you access to that care. And that does unlock not only the neurologist who really understands, but Kathy's presentation was so amazing because it demonstrated the complexity of need and all the different specialties that have to come together. And that's important not only for you or your loved one if you're helping someone with ALS, but our Congress people need to understand that as well. And I'm hoping you can carry that message forward, that it's not just a neurological disease, it's a disease that affects the whole system. All kinds of specialists need to get involved. There's lots of complex delivery issues, and we really need all of these different resources to make this work.
And, we only have a few minutes left in our session today. And Colony, I wanted to kind of round out the conversation with you. I have so many questions here coming through about specific symptoms, specific types of treatments that people should try or not try, when to start something, when to stop something, when should I look for a clinical trial, how do I look for a clinical trial? Obviously, our website is a wealth of information, and our chapters specifically are also a wealth of information. But what would you recommend to a lot of the questions that we can't get to today, in terms of where to find those types of answers about your specific medical or condition or your specific situation?
Yeah, I mean, I'm sure that we could probably keep Kathy here for another hour or two, and maybe still not get through all of those questions that you're getting. And I think we get them every year, right? And Kathy, I think it shows just how much knowledge people really want and how much they're really thirsty for. So I'm with you, Nicole. I would say reach out to your local chapters. They're just full of information. We also have, we've recently updated our website. There's a lot of information that's there. We also work globally, and we actually try to cull information from all over the world, and give information from all different kinds of resources. So if you can get online, do that. We also, even the questions, we have a hotline in a sense, and we always answer that. We try to get to things as quickly as possible within 24 hours, and that comes through the national office. And Kim McGinnis, who runs that program, will then farm those questions out if it's more appropriate for someone in a local chapter or a physician to answer. So there are a whole host of ways for people to ask these questions. So I don't want you to think that just because we're going to close out this session that then there's no one here to get to those questions for you. We will try to get back to you as much as we can from the questions that we have, if we have your contact information, and then we can answer those questions directly. But really dig into our website, into our resources, and reach out to your local chapter, and they will navigate you to, if they're not the right people to answer your specific question, they'll navigate you to someone who is. Thanks,
Colony. And
sure.
Unfortunately, we have arrived to the end of an incredible 3 days. And we've had, I think, as you've repeated over and over, close to 900 people participating, which makes for a lot of questions that we don't have enough time in the day or probably in this week to answer. So as we wrap up, I want to remind you, we have one final opportunity to visit with our sponsors and exhibitors. And that Zoom booth exhibit experience will start immediately after this session around 4:30. And it will be open until about 5:15. And I think I wanted to also just thank everybody for being with us today. Dr. Lohman-Hirth, we really, really appreciate you being with us today and presenting. There were probably more questions for you than you could imagine. And Tommy May, thank you so much. Dr. Neil Thacker, thank you again for being with us all week. And of course, Colleen, I'm going to turn the stage back over to you for some final thoughts.
Thanks, Nicole. Yeah, and yes, thank you, Kathy, Neil, Tommy, for a really great discussion. I'm hopeful that next year we'll be able to do this in person, and with that maybe spend an hour doing these kinds of Q&As, because I know how important they are and how much information people get. So I hope that you all have been as inspired as I have over these last 3 days. Again, just really taking away a lot of good information, learning about our goals together, about making ALS a livable disease by 2030, still looking for treatments and cures all along the way, of course. And I hope that you take away kind of what Tommy was saying. Get to know your local members, get to know them, have a conversation with them. You actually can make the difference by becoming an advocate and helping with all the priorities that you've heard about. There will be more, right? We absolutely need your help in advocating with Congress and the stakeholders. You know, we need more funding for research. That's how we're going to find treatments and cures. We've got to keep the ALS registry going. We need to pass Act for ALS and the Promising Pathways Act. And we need the Congress to fund the National Academies of Science of Medicine for that research that Neil was talking about earlier, really looking at the whole breadth of impact of ALS, the person living with it, caregivers, and the entire community. So these are just, I think it's a small to-do list, because I know that many of us could think of a bigger to-do list, and we already are, but these are the things that we're really going to focus on in the next few days. Finally, I have to thank some people who you haven't seen. There's been a lot of national staff, volunteers, technology gurus behind the scenes, making this all happen seamlessly. So thank you all. I know it's a big lift. Doing these virtual conferences are very complicated, and I just want to thank you for that. I also want to continue to thank our sponsors who have been committed, and Nicole mentioned that the exhibit hall is open right after this. So please go ahead and take a look and have a talk with them. And I want to take a special moment and say thank you to our caregivers. I know that this past year has been an even greater burden than maybe years before. And I know that your families are grateful for everything that you have done. And we are too. And we're here to help you and support you. And we want to see how our legislative efforts can help your life going into the future. So thank you. You never get enough credit, but know that you are the heroes. And I know the people who live with you know that too. And to all of the people living with ALS who are tuned in, I'm so glad that this format has really been able, and we've seen in the last couple of years, to bring new people in, maybe people that couldn't come to Washington had we just done this in person. So I'm happy that you were able to join us in this virtual way. So just finally, we're all advocates. We're all ALS advocates together. We all deeply care about the people that are living with this disease and their loved ones. And the only way that we're going to make this disease go away is to do whatever it takes to make it livable and to find new cures. So know that your advocacy matters. It does make a difference. It leaves an impression with every person that you tell your story. I wish you the best of luck in your conversations with Congress. Remember what Troy and Carrie said on day one. They're just people. They put their pants on one leg at a time like everybody else. So have I don't want to say fun, but kind of, enjoy the moment and know that what you are saying and what you are doing is going to impact the future. So thank you everyone for joining us, and I look forward to hearing all the stories of how your meetings went. Have a good rest of your day. Bye-bye.